I would treat her functionally. And then it would be, if it was my daughter and she was working around it, clearly she's not doing any damage to it, and I would let her live with it. If she developed mechanical symptoms, catching, if I had any indication that the labrum was torn, then I'd be talking about a surgical procedure significantly earlier. If she decides that swimming is important to her, or that she has instability, these instability events with her activities of daily living, then I probably wouldn't spend a whole lot of time with physical therapy, and I'd move on to correct the structural problem that is clearly causing the functional problem.
And a question for you. What do you expect to find from the surgical point of view? Try to image, to make a scope this girl, and what are the anatomical findings that you expect to find?
Yeah, no, I think that's a good question, and I was going to ask her if she had an MRI or arthrogram, because when I first saw her, the patients that I see with this, a lot of times will have some form of posterior labral abnormality and potentially a posterior capsule that's much wider. We published on some data of patients with posterior instability versus anterior and controls, and those with posterior had a huge capsule on MR arthrogram. Also, Dr. Kim out of Korea has taught us that although the arthrogram may be normal or interpreted as normal as a radiologist, you need to look at it because it may have labral cracks or a quote-unquote Kim lesion, loss of labral height. There's honestly still a lot I don't think we understand from this, but those are potentially the pathologic factors that you could go after if this patient was to elect surgery.
Ben, do you think that this patient, if you perform surgery on her, needs some application in the anterior-inferior punch and rotator interval closure?
I wouldn't touch her rotator interval. I really don't do a whole lot of rotator interval closures, even when I see significant sulcus signs. I'm not sure that that's particularly helpful. What I will do if I think that there's a problem anteriorly that involves the middle glenohumeral ligament, I'll bring it up where it belongs, and usually as I do that, I'm closing the interval to some extent. In this case, I wouldn't do anything with her anterior capsule. I would do a very specific exam under anesthesia and in the office as well to see is it looser up front, but the fact that she got tight in external rotation tells me that I've got a pretty good sling anteriorly, and I suspect that on this, with a careful arthroscopy, I think you would probably be able to see the transition from where it's lax to where it gets tight. I tend to think differently than some of the talks that you've heard about balancing the shoulder. And Gene Wolfe for a while was talking about the triad, where everybody with anterior instability got anterior, posterior, and intral. And then when he showed, I was sitting with Ben Kibler when he was giving one of the talks, and poor Ben was just going nuts. He wanted to jump out of his seat, and he just asked to see a picture of the patient post-operatively, and what Gene thought was a great result was about 120 degrees of elevation. So I think that we've got to be really careful about thinking functionally when we're doing our exam, thinking functionally when we're doing our surgery. And what I do is I get very sport specific when I'm doing my stabilizations and take the patient out of traction and after I do my capsulorrhaphy, to decide, have I made them tight enough where they need to be tight, and have I left them loose enough where they need to be loose? I mean, it's really easy to stop somebody from being unstable, just make them too tight.
Ben brings up some great points. Going back to the examination anesthesia, I can't emphasize enough that is only to confirm what you already know from the history and already know from the office. And I do exactly as Ben does, and I tailor maybe a final, if I'm going to put a stitch there or take some anterior, to help the examination anesthesia confirm that. And that sort of confirms my preoperative plan, but it may augment or change a little bit exactly where in the shoulder joint you go after. The second thing in the rotator interval, Buddy Savoy and I get into this debate numerous times, but I rarely close the rotator interval. I agree with Ben, I would not close it in this patient. She does not have a significant sulcus. Even if it does, it probably, and it looks like it obliterates an external rotation, so a rotator interval is working. She does have these repeated subluxation events, and if you believe the circle concept of Warren, where if you come out the back, you've damaged some of the front structures. There is enough evidence out there to say that this is probably not the case. And Steve Weber has shown us if you come out the back and dislocate out the back in cadaver specimens, the rotator interval is completely fine. And we've demonstrated that biomechanically. But the debate goes on how to handle the rotator interval.
Man, in this set of patients, do you check the range of motion after surgery, and do you give this kind of information to your physiotherapist to improve the rehabilitation to be much more precise during the range of motion, during the physiotherapy?
Yeah, that's what I was saying. When I'm done with the capsulorrhaphy or the bank card, I take the arm out of traction and check their range of motion. I check their stability, make sure I have them tight enough, and I check their range of motion to make sure that I left them loose enough. And that's always in the operative report, so that they know what the goals are, because there are times, honestly, that you made the patient just a little bit tighter than you really wanted. And is that a patient that you really want to go back in and start cutting things out and resuturing it, or do you just want to say, you know what, let's just push them a little bit more, a little bit earlier, and I'll get that range of motion.
I think that we are trying to do in Italy is just to improve, and I think this is one of the key points, to improve the communication between surgeon and physiotherapist. I think that sometimes this link is missing.
I think another good point in this patient with this positive Gauge sign and this inferior laxity is that if this patient is going to go to surgery, I think an important part of this repair is probably inferiorly, and you have to have strategies to get down there. Look at this inferior capsule because clearly she has inferior hyperlaxity that may be contributing. It is probably predisposed to it, but through her injuries and repetitive micro trauma, as you will, to this, she's stretched this area out.
I think we have to call it here. You need some time to get to the next session at 11 o'clock. Thanks for your time and attention.